think that's a great transition to the next point we wanted to bring up, and that was around contracting and costs. And really, so the point of that is we need to lower the screen on what these drugs cost and make more people aware of the return on investment of these drugs. But my point in this was that if you look at the drugs and the regimens, it's sometimes hard to compare apples to apples. So we really need to be looking at the duration of therapy, the cost per cycle, but then cost per month, cost per year, and look at it multiple ways, because if we don't do that, we might miss something and we might be making inappropriate comparisons. And furthermore, we really need to look at the cost of adverse events. So it's a total cost package, because if one drug causes 50% anemia versus another drug that's 10%, or neutropenia, or whatever it may be, that should really be factored into the cost of that drug. So the cost discussion really needs to be around total cost, but we need to kind of remove the curtain from the cost of these things and make other people more aware of it. And then rebating is also an important component. Now, historically, rebates have not been available in oncology, but we're getting there. There actually is contracting available in prostate cancer with the TKIs that were mentioned earlier. So that's an opportunity for us to work with the pharmaceutical companies and bring them into the picture a little bit more. But we have to have the ability to have that discussion, and without our willingness to work with the providers on making formulary decisions, we're not going to have the ability to go back to a pharmaceutical company and try to lower the cost of the medication. So the next subject we wanted to talk about was tools for providers and how managed care can help support them. And the couple of concepts that I had written down was the first one was end-of-life tools and end-of-life counseling. And I'll admit, I don't envy you guys sitting there talking to patients and having that discussion towards the end of life, because, to say, well, I don't think this is a good idea that we use this treatment, you only have X amount of time to live or something like that. That's an uncomfortable discussion. So I don't envy that, but I think that those types of discussions have to be made, because at some point there probably is not any kind of return on investment for these drugs in certain patients. So can we help you provide that? And are there services out there that we can contract for that maybe shifts that discussion from you to somebody else, or at least bring somebody else into that discussion to help you have that? And one of the things that we're working on at my company is more robust medication therapy management and more robust integrated care management. So everybody does this, but in most cases it's very, very siloed. So you might have nurses over here doing one thing, pharmacy over here doing one thing, and there's very little collaboration. So what we are trying to do is put pharmacists, nurses, and social workers together on integrated teams and really have them be in charge of a patient, and then bringing the provider into that. So there's got to be an opportunity, I think, for us to help you guys do a better job of providing the options and having a frank discussion with patients.
So, I think, in fact, the concept that an enhanced clinical support approach, which is a soup to nuts approach, including a medical home type approach to patients during active treatment, a focus on appropriate patient counseling regarding end-of-life care. I think if you're a true optimist and a real believer in the way healthcare reform has been crafted in this country, that's actually where they want to go. I think they want to make the system so good at the local level that the patient will want to be sticky to their provider. They'll be getting such excellent care from their provider. And not only will that care result in an enhanced patient experience, I think a lot of us truly believe it will reduce cost. And then we won't have this argument about whether you should combine enzalutamide and abiraterone, because if you look at where the money is spent in the last 6 months of life, it's not on drugs, it's on hospitalizations.
Right.
It's overwhelming. It's 80% of the spend. That's published information. And you know what? If you've taken care of enough advanced prostate cancer patients, you know that's true. They're in for pain control, they're not eating, they're dehydrated and hypercalcemic because they couldn't come to their office for their bone agent. That's what happens. So we can do better. We can do better.
So I think it's interesting that you raised the point in the last 6 months of life of it not being about the drugs. Now there's an element there, and that may change if we use the drugs inappropriately, so we have to be careful. But just on this end of life discussion, I don't just treat prostate cancer, and prostate cancer patients do relatively well, but I look after patients with bladder cancer and kidney cancer, and their prognosis is actually not as good. And kidney cancer has improved a little bit lately, and we can control the disease with systemic therapy. But you know, I have an end-of-life discussion with patients with metastatic disease as part of the first or second visit. And usually it's a prostate cancer patient who's in his 60s or 70s does not necessarily want to have that discussion in front of his family. But will understand that if he's got recurrent disease, that the stuff is likely to kill him. And we'll want to do some sort of planning, and I think we miss that opportunity sometimes. And then the issue at the end is keeping the patient ambulatory and moving as a goal, because the quality of life is better, and keeping them out of hospital. So there are no patients that want to be in hospital, and there are no patients that want to be in pain. That one of the big issues they have is they have a relationship with their urologist or radiation oncologist or medical oncologist. And some of the problems we've had with palliative care up until 2 years ago was, oh, you must be within 6 months of death, right, to go on to do hospice care or even have an evaluation. And then when you go on hospice care, you will not be able to go back and see your doctor who may have been with them for 20 years. And the issue that those two things are immense barriers. Now, the things largely to ASCO, but also to some of the insurers. We have now, that 6 month thing has sort of gone away, and we're able to get an evaluation, so they meet a hospice team. And where the hospice team's good is that if there's an acute thing at home that could induce an admission in someone who's terminal, instead of them coming to hospital, provided you know what the therapy should be and what support they need, you can actually get them treated in the home with a fairly efficient team. And you know, they'll often get them better, and they'll come back to the office for review. And cutting the cord from it's usually the oncologist, but not always. It's sometimes a radiation person or a urologist is very difficult for some patients. Well, I guess I'll never see you again. We've travelled often some years, and that really scares them because they're going to a situation they don't know about. So I think we need to work on trying to integrate that. And I philosophically have always stayed involved and started in a system where we had integrated care to the end of life, so that we were involved, and maybe over the telephone rather than in office visits. So yeah, I think there's something there where we need to look at some common goals.
So I get to brag about an Aetna program. Aetna's had a program called Compassionate Care.
I thought I introduced that really well.
Thank you, that was perfect. So Aetna's had a program called Compassionate Care, which has an enhanced hospice benefit, has a trained team of nurses and social workers and dietitians that telephonically outreach to the patient, communicate with the provider. It has been shown in peer-reviewed, published data to reduce cost of care at end of life. So why does it reduce cost of care? Well, you can guess. The patients don't go to the hospital, right? And so I totally agree. I don't think, I personally would terribly object if somebody tried to get between me and the patient I've had a long-term relationship with. It's not that those visits are fun. They're not fun. They're challenging, but they're important.
Yeah.
No, I think you're right. I think this whole concept of managing, of having a medical home, being able to more effectively manage those patients, whether it's telephonically, whether it's cloud technology, whether it's wireless technology, that ability to keep the patients out of the hospital, to keep them in an outpatient setting, there's no question that should definitely decrease the cost. And, a friend of mine says there's wellness, illness, and willness. So you've got a certain amount of patients that will always be healthy. They'll never access the system. There's going to be a certain percentage of patients that will unfortunately always be in the hospital. And then there's going to be this 30 to 40% group that, depending upon how you manage them, could actually be managed very effectively, cost effectively at home without them ever having to be hospitalized.